Hello and welcome, everyone. Thank you for joining us in today's webinar brought to you by the Critical Care Nurses Association of the Philippines Incorporated. Kindly stay tuned as we will start our program after we show some important reminders, followed by a short invocation, the Philippine National Anthem, and the Sisinapi hymn. Thank you.
The Sisinapi Online Learning Reminders.
Background noise. See that there is no disturbance like background noise or people moving around to avoid distractions. Sit in a good lighted and noise-free room. Test equipment and internet speed. Check laptop, desktop before joining the webinar. Choose a spot with an unlimited and strong internet connection. Use headphones or earphones to reduce the background noise. Log in on time. Be on time. Join every session at least 10 minutes prior to the session. Value other people's time. Mute your microphone and camera off. Please put your microphone on mute and camera on off during the session to avoid interruption of the presentation. Be polite. Do not interrupt. Leaving the session. Do not close or leave the Zoom application during the session to avoid being logged out that will result to incomplete attendance. Asking questions. All questions will be entertained after the presentation. You may type your question on the chat box so that the moderator can take note of it. Please keep your questions minimal and on the topic. Be prepared for technical difficulties. Just in case of technical glitches, kindly send us a message through email or social media outlets or through SMS. Profile and display name. Choose a suitable profile picture. Name yourself formally the way you want to present yourself. Certificate of Attendance. Certificate of attendance will be given only after the participant has accomplished quiz and evaluation. The QR and link will be shown on the screen and will be emailed. Automated certificate will be sent. Make sure to input your correct details. Self-directed learning application. The certificate of attendance for this online session may be used for PRC's self-directed learning application. The organizer will provide you with a certificate of attendance together with a PRC guideline on how to apply for self-directed CPD units and the application form. To maximize your self-directed learning application, you can collate all the certificates of attendance that you earn from webinars into one self-directed CPD application. This will consolidate all the credit units for the required year or for 3 years. For renewal of your PRC ID, you need as much as 15 credit units earned for the 3-year period. For other concerns, please feel free to contact us.
At Cincinnati, we care for a better world. This is our passion beyond our profession. Committed we'll ever be to learning, training. We continue equipping, be the best that we can be to care for humanity. We draw strength from God Almighty. We care for patients to restore their optimal well-being and live a life of quality. See healing flow through the love we sow with high touch, high tech at Cincinnati. We care for a better world. The world needs more people who care, and we are a people who dare. We give all we are, we give only our best. We are the Critical Care Nurses Association of the Philippines. We are Cincinnati. At Cincinnati, we care for a better world. This is our mission, our pledge to the nation. Committed we'll ever be to learning, training. We continue equipping, be the best that we can be to care for humanity. We draw strength from God Almighty, and through Him we set people free. From darkness we hold on to life and see healing flow through the love we grow with high touch, high tech at Cincinnati. We care for a better world. With high touch, high tech at Cincinnati. We care for a better world.
Good day, my fellow nurses, to this 2-hour webinar entitled Updates on Coma Management Roles of Critical Care Nurses. This program was created to support the campaign of the Neurocritical Care Society towards curing coma. This initiative was launched in October 2019 during the 17th NCS annual meeting in Vancouver, Canada. And last March 22, 2022, the Neurocritical Care Society and the Curing Coma campaign had their second annual celebration of World Coma Day. The message of this campaign is that there is hope for individuals suffering from prolonged disorders of consciousness after brain injury, since coma is considered by the experts as a unique modern clinical challenge. My name is John Christian Agustin. I am the Vice President of CCNAPI, and I am honored to be your moderator for this webinar. Would like to remind everyone that for you to receive your certificate, you must first need to take the post test and answer the program evaluation at the end of our webinar. For now, let me give you a brief introduction about our webinar. In 2019, the NCS launched Curing Coma campaign as the first global public health initiative to tackle the unifying concept of coma as a treatable medical entity. The goal of Curing Coma is to develop and implement coma treatment strategies that improve human lives. This for our webinar, 2-hour webinar, will give the participants an overview of care of patients suffering from an alteration of consciousness. In addition, this program will provide the nurses with an in-depth understanding of the different state of consciousness, techniques in assessment, monitoring, and nursing management. Moreover, this educational activity supports the campaign by the NCS in the curing coma. And the specific objectives of this webinar is that the course aims to highlight the importance of advanced assessment skills and tools used to validate comatose status of a patient, differentiate the different disorders of consciousness, explore the importance of the different diagnostics that can be done to aid diagnosing patient with coma, and lastly, to discuss the different nursing management of a patient who is comatose. To share us the rules of critical care nurses in managing coma patient, we have invited a professor and a certified critical care nurse from Dallas, Texas. He had his can we have the next slide? He had his Bachelor of Science in nursing in Takeo Maricrest University, Iowa, and took his doctorate degree in the University of North Carolina. With over 30 years of experience as a clinician and an educator, he held numerous positions in various professional and scientific societies. He has dedicated his time on developing a more comprehensive understanding of how nursing care contributes to patient outcomes following a brain injury. For that reason, he was able to publish over 250 manuscripts, 16 book chapters, and 215 scientific abstracts. His passion in neuroscience and research reflects by being an active member to different organizations such as World Federation of Neuroscience Nurses, American Association of Neuroscience Nursing, Neurocritical Care Society, and International Association of Nurse Editors. He is also the editor-in-chief for the Journal of Neuroscience Nursing and the co-chair of the International Neurocritical Care Research Network. In addition, he is a recipient of numerous awards. He received the Excellence in Nursing Award from D Magazine in Dallas, Texas in 2021. And in the same year, he was given the Best Paper Award by the World Federation of Critical Care Nurses for his research entitled Lack of Standardization in Determination of Intracranial Pressure, which was published in Connect, the World of Critical Care Nursing. Currently, he is a professor at the University of Texas Southwestern teaching neurology and neurotherapeutics and neurosurgery since 2012. Without further ado, let us all welcome Professor Daiwai Olson. Professor Olson, the screen is yours.
Thank you very much, and thank you for that introduction. I'm going to do a quick screen share, and I think I have to do a screen swap as well, right? JC, which screen are you seeing?
I can see, sir, your presenter's view, sir, with notes.
Perfect. Okay, so that should be better. And up, I'm going to leave my camera off, I guess, for internet purposes, and then I'll turn it on for the presentation. Does that work for you, or would you like my camera on?
It's fine, sir.
Fantastic. We're going to get started. We have 2 hours of content to cover and a lot of topics to discuss. So first and foremost, I do want to thank the CCNAPI for introducing me and for inviting me to provide you with some updates on the management of patients in coma. And this is specifically for critical care nurses. But in general, I think any nurse can benefit from this content. I would also like to acknowledge the fact that I think it's now been just over 10 years since my first NCS or my first CCNAPI presentation, which is hard for me to fathom. It's been a long time. These are my disclosures. I think the most important disclosure for you to consider looking at is that I am the co-chair of the Curing Coma campaign. I have received research funding from a number of different institutions. Let's get some definitions solid. Care and cure. We use those words a lot. We use care and cure. And care can be caring about, right? I care about a person. This is an emotional response. On some level, I would hope that all of us care about the patient that we are providing care for, but also there's caring for. And caring for is different from caring about. Caring for is all the things we do. It's every nursing intervention, it's every action, it's every assessment that we perform on a daily basis to meet the needs of the patient. Caring and curing work hand in hand. Physicians tend to focus on curing, right? They try to remove the disease from the patient's body. They try to rid the patient of disease. That's their focus. That doesn't mean they don't care about the patient, and it doesn't mean that sometimes they don't care for the patient, but their focus is cure. In nursing, our focus is care. That doesn't mean we don't help cure, but it means that our focus is slightly different. So all humans care about other humans. I hope all humans, right? Nurses care for patients, and physicians cure from disease. That's a primary basis for understanding what I'm going to talk to you about in the next hour or so. So if we look at the physician model, one doctor, one physician is often assigned care of many, many patients. But really, he's tasked with, you got a whole lot of people and you got to cure them, right? Whereas nursing tends to be a much more intimate focus. We aren't usually in a day, and especially in critical care, we're not assigned 100 patients. And if you are, you need to talk to the powers that be. That's too many. We are assigned a discrete number of patients. As many of you know, in the US, and I work in Dallas, Texas in the ICU, our ratio is 1.5 to 1. This allows us over the course of a 12-hour shift to have an intimate relationship with the patient. And I don't mean an intimate sexual relationship. I mean, we get to know the patient. We really, really understand the patient as a holistic human being. We develop a sense of caring about that's linked to our caring for, and we act on behalf of the patient as their agent. Nurses and physicians work together. I'm not arguing that it is nurses versus physicians, that one is better than the other. I'm a nurse. I have friends who are physicians, love my physician friends, right? But they're not better than me. They're not worse than me. They're not better than me. We have a different focus. We should be proud of that focus. And we should recognize that healthcare is a combination of nurses, physicians, therapists, and so on. If you look at the caduceus, that symbol that the physicians all seem to wear on their chest, it's a staff. It's called the rod of Asclepius. It's a staff surrounded by two snakes. The two snakes are not originally part of the caduceus. The rod of Asclepius was the physician symbol. The two snakes come from the goddess Hygeia. So when we think of healthcare, the primary symbol of healthcare is the caduceus, which is nurses and physicians working together. It's Hygeia along with Asclepius. That's the caduceus. So we really have to think about how we interact together in order to understand what we as nurses can contribute to care, and in this case, to care of the patient in coma. Let's look at a typical day of a patient in coma. 24 hours of the day. I'm using military time here. I don't know how things are at your hospital, but at my hospital in the ICU, sometime in the morning, usually fairly early in the morning, the neurosurgery team or the neurocritical care team, they come by and they round, right? They come by and they look at the patient and they discuss every aspect from head to toe, all of the systems. They write a set of prescriptions. They help designate like what are the goals for the patient today, and that's a big deal, and we shouldn't ignore it. But I want you to look at this. Look at the screen, and what you see is you've got about 20 to 30 minutes during a 24-hour period where the patient is interacting with the physician. And at my shop, it's actually not 30 minutes with the physician. It's 30 minutes with a group of about 12 people, one of whom is the physician. The other 23 minutes, 23 hours and 30 minutes of the day is nursing care. So we should not ignore what our physicians do. I'm not saying that. But we also can't ignore what happens for the other 23 hours and 30 minutes. That's all kinds of other professionals, primarily in critical care. That's us, that's the nurses. I'm going to make three simple arguments. And you can write these down, but you'll see them again. I'm going to argue that if the comatose patient dies before there is an opportunity for cure, then the possibility of recovery is zero. If the patient is dead, I don't care how brilliant the physician is, that I know of, except for that TV show, The Walking Dead, and I'm addicted to that TV show. Nobody comes back after they're dead. Argument number two, if we as nurses discover the caring for variables, the variables associated with caring for, and I'm going to warn you ahead of time, I'm going to talk about some statistics later. If we as nurses discover the caring for variables, we can reduce sample size. In other words, you don't need as many patients in the study to show whether or not cure interventions are effective. Kind of complicated, but we're going to walk through it together. And the third one, as you can see from the first few slides, nurses are key. If we are going to cure coma, we are going to need nurses. everyone listening to me now is part of the Curing Coma campaign. You may not have signed up. You may or may not have attended a World Coma Day. We had 100 countries. We had, I think, 15,000 people that signed up. So we have a lot of people, and I hope you were one of them. But even if you weren't one of them, you're part of the team. Even patients are part of the Curing Coma campaign. Let's start with this first one. If we don't provide good care, we can't cure. I was kind of blunt earlier. I said if the patient dies, you can't cure them, right? So somewhere we have to think about care. We are the nurses. We're in the front lines. We are at the bedside. No one else is going to do our tasks. How many physicians have you seen cleaning up poo? How many physicians know where to get the medications? How many of the physicians know how to really titrate an IV? That's not their job, right? That's not what they're tasked to do. So it doesn't matter how smart the physician is, they have an entirely different role than we have. We're tasked to care for the patient. If we don't do our job, the patient dies. That's my first argument. And I don't think I have to hammer too hard on that one. That one's an easy one for me to win. If we don't do our job, the patient dies. If the patients did, it doesn't matter how good a physician is. Let's go on to number 2. Discovering the care variables will reduce the required sample size to discover the effectiveness of curing interventions. Kind of complicated. The first thing we're going to talk about is effect size. And we need to understand effect size. And I don't think it's been taught very well in schools. So effect size is simply the magnitude of any given effect. What you see in front of you is 3 sets of bell curves. These are also called normal distributions or Gaussian distributions from Gauss. And I have shown 3 different distributions on these curves. In all 3 cases, let's pretend we did an intervention test. We wanted to test whether or not tenecteplase, which is rapidly replacing alteplase for thrombolytic for ischemic stroke, whether or not tenecteplase results in a lower stroke score. NIHSS, for those of you who don't know, stands for the National Institute of Health Stroke Scale. It ranges from 0 to 38 if you do it correctly. It ranges from 0 to 42 if you do it wrong. 0 is us. We're all 0. We have no deficits. 38 is a dead person. So that's the worst you can get. 19 is worse than 10. And when you're looking at this, I want you to say, okay, so is there a statistically significant difference between 19 and 10? And I'm going to tell you in this hypothetical example that there is a statistically significant difference in all 3 examples between 19 and 10. But there's not the same difference because the effect size in the top example is very large. There's a big difference between 19 and 10. And we'll talk about distribution in a second. In the middle slide, there's a medium effect. And in the bottom slide, there's a difference, right? And there's a statistically significant difference between a 10 and a 19. But if you look at that distribution, wow. This is almost overlapping. So effect size takes into account not only is there a difference, but how big is that difference? And effect size becomes very important when we're calculating the sample size needed. The reason that's important, let's pretend that your favorite physician thinks he has discovered the cure for coma. And he has a small effect size. It's statistically significant, but it's small effect size. In order for him to prove that his cure really works, he needs thousands of patients in each group. But if instead we had a smaller standard deviation, he could have a larger effect size. And the standard deviation comes a lot because of confounders. Let's think about it this way. I'm going to use a hypothetical example. This is my regression formula. Y equals beta naught plus beta 1x1 plus beta 2x2 plus beta 3x3, et cetera, plus that funky symbol off to the right. That's an error term. And this is kind of messy. And some of you right now are having like post-traumatic stress remembering your statistics class and in your undergraduate nursing degree. And we're going to talk about statistics even more. But I'm going to try to make it a little bit easier because I think we all as nurses really, really should understand statistics. For some of you, I hope this is going to help because you've seen this formula a lot, but no one really took time to explain it. This is a standard regression formula. Y is predicted by a bunch of things. And oddly enough, we put the Y over to the left, and we read this as the outcome is predicted by where we started, plus the influence of a whole bunch of other variables, plus error. The outcome is predicted by where we started, plus the influence of a whole bunch of variables, plus error. I'm going to color code this for you. So the outcome is going to be blue. That's the Y. Y is predicted by is that equal sign, where we started, the beta naught, right? The BO, plus the influence of a whole bunch of variables. And each variable is listed as a beta and an X, beta 1, X1, beta 2, X2, beta 3, X3, plus error. That's going to come up important, right? So the outcome is predicted by where we started, plus the influence of a bunch of variables, plus error. And I'm hitting this hard because this really, to me, explains why nurses are so important to curing coma. I'm going to use another example. We're going to stay on this regression formula. 90-day modified Rankin score. Now, modified Rankin score is something we use a lot in stroke. It goes from 0 to 6. 6 is a dead person, 0 is a normal person. 90-day modified Rankin score is predicted by how well the patient was before their stroke. In other words, if before my stroke I was in a nursing home and I have a stroke, it's kind of unlikely that the stroke is going to make me better and I'm going to be able to compete in the Olympics. But if I started out as an Olympian when I had my stroke, maybe I can get back to being an Olympian. So that's where we started. Plus, NIH, how bad was my stroke? Plus my age, I happen to be 60, right? Someone who's 20, a lot better chance of recovering. They got a lot more time to recover than I do at 60. Plus, did they get a thrombolytic? And oddly enough, sex, we know that male sex is a predictor of worse mortality. And then there's a whole bunch of other things we could measure, right? Did they smoke? Were they hypertensive? Lots of other variables. Going back to our color-coded version, this is the same as saying their discharge modified Rankine score, the blue, the Y, is predicted by their baseline. How were they at baseline? Plus lots of things. NIH, age, sex, ethnicity, obesity, smoking, lots of things, plus error. The problem I have is that one of those big other things that we don't measure, that's nursing care. You never see it in the formula. You never see that stroke recovery is predicted by age, sex, injury severity, nursing care, smoking, right? You never see that in the formula, but it's important. I really, truly think nursing care makes a difference. I would ask you all to raise your hand right now if you believe nursing care makes a difference. And if any of you said no, I'd probably have to do a Chris Rock imitation there. Nursing care is important. It's really important. But can you measure how important it is? Can you put a number on how the last patient that you took care of, can you put a number on how important your care was to the success of that patient's outcome? Let's take it another way. We're still doing regression now. We're still on regression, but you're going to see it take another form. There's some sort of event that happens. In my example, that event is a stroke. Then there's a lot of variables that go on. There's a big intervention. Did they get mechanical thrombectomy? Did they get a thrombolytic alteplase or tenecteplase? There's other variables. How bad was their stroke? What was their function at baseline? Age, sex. We talked about all of those things. There's some confounders, some things we don't actually know, right? Do we know whether or not income is a big deal? We've got hypothetical models, higher income is somewhat associated with a better diet, but not always. What about where they live? What about altitude? Does it matter if you have your stroke and you're way up high in the mountains or down at the sea? These are confounders. We're not sure. There's some hypothetical reason to believe that these would be important, but we don't actually have fact behind it. And then there's nursing. And you'll notice I put nursing in as a confounder. I put nursing in as a confounder because I am, as a nurse, and I've been a nurse for just over 40 years now, as a nurse, I know that I've done some important things. Think right now about the last patient you took care of. Did you do a good job or a crappy job? Did you make a difference? Right? How many decisions did you make? What did you do? You made a difference. But we have to put that into mathematical terms, or it's not going to get into that other equation. So the little r square is the one-to-one relationship, saying univariate, one variable. Some people say univariable, right? So variable 1, let's pretend that it has an r squared of 0.1. We'll talk a little bit more about what r squared is. And variable 2 has an R squared of 0.1, and 3 is a 0.1, and 4 is a 0.1, and the intervention is a real big deal. That's a 0.3. And I will tell you that R squared goes from 0 to 1. And this is basically proportion of variance. R squared is a proportion of the variance. What proportion of the variance in the outcome is attributed to the interventions? And my question is, what proportion of the variance in outcome can be explained by nursing care? How much does nursing care explain the outcome? I'm going to give you a little bit of an example of what we mean by proportion of variance in outcome. How tall you are is extreme. A lot of the variance in how tall you are is explained by how old you are up to a certain point, right? There's not many people who are 18 years old and are still like 19 inches tall, because as you age, you get taller, but at some point you stop. So if we looked at the proportion of variance in height during the first 7 to 10 years, a large proportion of the variance in height could be explained by age. Some of the variance in height is explained by how tall were your parents. If both of your parents were tall, you have a higher likelihood of being tall. Some of the variance in height is explained by, are you male or female, right? So if I know that if I said to you that the patient is a 4-year-old female who's the child of 2 very short people, would you expect that that person is 6 feet tall? No, that's preposterous. But what if I said to you, this is an 18-year-old male whose parents both played basketball? Okay, now I'm picturing someone taller, right? So by knowing the proportion of variance, we can build a model where we explain some outcome. In this model that you're looking at, the R squared has changed from little to big, because a big R squared is more than one variable. And in this case, if I lump all of these together, I explain 0.7. I explain 70% of the variance by knowing how much of the variance of each variable is attributed in the full model. Imagine if I knew nursing. Like if I knew nursing, I could explain way more than 70%. My R squared would go up significantly. There's a lot of things we don't measure. It's not just nursing. We don't measure, was the patient born on a Saturday, right? We don't measure, this is stroke recovery, right? We don't measure whether or not the patient likes coffee. We don't measure how many of the patient's friends watched the movie Frozen. We could measure it. We could measure that. But we don't measure it because we don't think it's important. We could ask, right? How old was the patient's grandmother when she first ate cheese? We could measure that. We could get an exact number. We could fit it into our regression formula, and it probably would make a whole bit of difference. How many times did the patient go to the beach? Well, maybe that, I mean, is that going to make a difference? Well, I guess if they've never been to the beach and they live in the Philippines, you got to kind of wonder, like, are they sedentary or something? The beach is, you guys are surrounded by beach. So some of these are also construct dependent. In other words, they're dependent on the environment and other things. There's lots of things we don't measure. Given that there's lots of things we could measure but don't measure, why do I think we should measure nursing? And the answer is because if we measure nursing and we find out how much of the outcome of patient outcome, how much outcome is attributed to nursing. Good nursing care makes, in my hypothetical model, good nursing care makes 15% of the difference. That's huge. That's a big deal. 15% of the difference can be explained by whether or not they had good nurse. If you do that, if you think back to our effect size, right? Now we can narrow down the standard deviation in our groups, and we don't need as many patients to test the cure that the physician has. So we can have a better model, a better test. I've been talking about stroke, but I'm going to now talk a little bit about coma. I used stroke because a lot of us are a little bit more familiar with that. Coma, you know, I used to really know what coma was, and now the more I learn about it, the more I'm really thinking about so many different types of coma, and we have phenotypes of coma and genotypes of coma. So here's our model now, still regression. A patient is in a coma. There's a whole bunch of care things done, and you'll notice I made this a black box. I made it a black box because we don't actually know in 2022, we don't actually know what care the patient gets. If you've taken care of a patient in coma, or a patient who's comatose because of sedatives even, or paralytics, or maybe they're in hepatic coma or anything, right? What did you do for them? Well, you washed their face, that's for sure. You gave them their meds, you started IVs, you turned them, you did skin. How many things did you do? How many interventions did you do? Do you think you should have skipped some of those interventions? Do you think some of them were just stupid and unimportant? Maybe patients don't need to be turned. Or do you think maybe the fact that you turned that patient helped them stay alive? The fact that you did skincare. We as nurses, we do a whole lot of stuff very intentionally. I talk to my coma patients. I think that's good. Not sure. Don't know how much of that my care interventions contribute to cure. But I do know that for some reason, some patients in a coma get a whole bunch of interventions. We have physicians who try to cure them, and some of them have full recovery. Some of them have partial recovery, and some of them don't recover at all. And to me, the biggest unexplained variable is nursing, because nobody wants to measure it. I shouldn't say nobody, because I sure as hell do. But we're not measuring it. We don't have an R squared for nursing. So that's my second argument. And I do want to try hard to leave time for questions. I promised JC that I would do that. And it looks like there's starting to be some questions now. So please type your questions in. So my third argument is we have to discover those care interventions. Now we call that routine care or normal care or whatever, right? Just the stuff we all do. We pass it off like it's unimportant. We pass it off like it's routine. We need to discover those routine care interventions. How much of them help move the patient towards recovery? How much of them help? How much of them hurt and move the patient away from recovery? We're going to talk about that a little bit more. I want to remind you, I said nursing care makes a difference. I said I do not know how to measure it. I said I'm trying. I never said we don't have a theory, and I certainly didn't say I don't have a theory. The theory I have, and I hope some of you have read this because I don't want it to be just my mom that's read my papers. I have a theory called the cue response theory. And in this theory, I'm going to start way over here on the left at event. I don't think you can see my mouse, right? I guess they can't see my mouse. I'm going to start over here on the left at event. Some event happens, something. They get hit by a baseball bat, or they get shot in the head, or they have a car crash, or a stroke, or an aneurysm, something happens, and that's their primary brain injury. That's the event that starts it all. And that event causes impaired brain function. After they get hit with a baseball bat, they're just not the same as they were before. They get admitted to the hospital. Patients give off a lot of cues. We as nurses, we see those cues. Our nursing assessment picks up on them. And by cues, I mean all kinds of stuff. The patient's heart rate goes from 80 to 110. Boom, I'm on it. That's a cue. The patient was moving their right arm. Now they're not moving their right arm. Boom, I'm on it. That's a cue. The patient was able to squeeze my hand pretty strongly, and now it's, you can't measure it. You can't put it on that silly 1 to 5 scale, but it's not quite as strong. And when I said squeeze my hand before, they were like, squeeze. And now I say squeeze my hand, they're like, kind of squeeze. Right? They still get the same score on that number scale, but it's a little bit different, right? We as nurses, we can see the subtlety of that patient change because we have developed the intimacy that comes with caring for. This is what Dr. Sandalowski called knowing the patient. We've come to know our patient. We understand our patient. So as nurses, if you look in this middle where it says nursing assessment, we've got all kinds of interventions we can do. I could turn the patient, I could suction the patient, I could give them a bath, I could give them some medicines, I can give pain medicine, I can reposition them, I can rub their feet, I can slap them across the face, I can do all kinds of different things, right? I have tons of interventions in my back pocket that as a nurse, I'm ready to employ. Turn the lights on, turn the lights off, turn the TV on, let the family sing, tell the family not to sing. These are all interventions. And based on what I see happening to the patient, based on the cues that I see, I decide when to use certain interventions. And when you use the intervention, not just which intervention you do, but when you use an intervention is just as important as which intervention you use. And you're going to see that in a few slides. So the timing of the intervention is super important. Okay. I'm going to give you a simple example of timing an intervention. You're on your way home now, and on your way home, you get off the jeepney. Right? Most of you, I don't know if you take jeepney home or whatever, but you're on the jeepney and so you get off the jeepney. That's the intervention. That was what it. But think about when. Are you going to get off it while it's going 35 kilometers an hour? That's bad timing. It's not just what you do, it's when you do. Are you going to get off it, even though it's nicely stopped, when it is 10 kilometers away from your house? Or are you going to wait till you're a little closer? There's a timing with that. Well, that carries through to what we as nurses do. And I want you to lock in your mind right now. I want you to think about a patient you've taken care of, whether they were comatose or it doesn't matter. Think of all the many things you do where you've decided when it happens. The arrow points to the PubMed link, and this is available. If you Google Q response theory, or myself and Dr. Ortega Perez out of Bogota, Colombia, published this several years ago. There's a YouTube video. It's about 2.5 minutes long where I explain this theory as well. So I don't want to go too deep into it, but I do want to acknowledge my co-author on this theory, Dr. Stephanie Ortega Perez, who published this when she was still prior to receiving her doctorate, about 3 months before she got it. And she is in Bogota, Colombia. Some of you may have seen her at the World Federation of Critical Care, and also at a lot of the other nursing highlights. So going back to the Q response theory, I just want you to look at this and see that if you do something at the wrong time, let's look at the top part. If you do an intervention at the wrong time, then you move to the left. You go back to making their brain worse, chaotic activity, continued brain injury, secondary brain injury. If you do it, go down to the bottom. If you do it at the wrong time and you cause secondary brain injury, that worsens their function. If you do your intervention at the correct time, if you get off the jeepney at the right time, you move closer to home. If you do your nursing interventions at the right time, it helps the patient regain organized brain activity and they recover. If you do your intervention at the right time, you decrease secondary brain injury and they recover. Here's an example, instead of the jeepney example, very specific to coma. This is an example where it's bad timing. The physician says, I would like to know how much the patient weighs. Okay, that's an intervention. I know how to weigh the patient. The physician wants to know. I walk into the room and the intracranial pressure was 7 when I was here 5 minutes ago. And now it's like 18. Over the course of an hour, it's gone up from 7 to 18. That's my cue. But I'm a brand new nurse and I go, well, I only have to treat it if it's over 20. See, I didn't pick up on the cue that it was going from 7 to 18. So because the physician wants a weight, and I got some other things to do too, I lower the head of the bed, put the patient's head down flat. I weigh him. We have, those sling scales some of us have. While I'm there, I might as well bathe him. So I bathe him and I change the linens because you got to have those linens looking good, And then when I look again, his ICP now is 35. His right pupil is fixed and dilated. Hopefully some of you are going, holy shit, patient herniated. I killed that patient. Well, I didn't kill him, but I sure as heck didn't help him. Right? I timed my interventions pretty wrong. Right? This is poor timing. This is directly attributable to the nurse. Here's why that's important. I can think of a lot of ways we can measure bad nursing care. It takes the nurse 25 tries to get in a 20 gauge IV. The patient has 19 extra holes in their body, and they were on aspirin, and they end up bleeding down. That's kind of bad, right? The patient says they have chest pain, and the nurse ignores it. The nurse comes back 5 minutes later, and this chest pain is now a full-blown MI. The nurse still ignores it. Patient goes into VTAC and dies. This is bad nursing. Okay, if bad nursing can make a change in the outcome, then good nursing must also be able to make a change in the outcome. If a nurse can do bad, then a nurse can do good. That's my simple argument. Here's the same example with different timing. The physician wants a daily weight. Yay for him. Now, over the course of an hour, my intracranial pressure went from 7 to 18. And I pick up on that cue. I'm like, this is trending up. Better think about this. Instead of lowering the head of bed, I raise the head of bed. The patient has some PRN analgesics. Well, this seems like a PRN time. So I give their analgesic now. The weight can wait. I get my weight for this physician, but I get it later on. Because of this simple change in timing of using my backpack of interventions, I've moved the patient towards recovery. So I have a theory as to how nursing care makes a difference. Now I got to figure out how to measure it. I haven't figured that out yet, but I'm working on it. Here's some other examples of caring for the patient that I think will impact consciousness. And what I want you to do right now is scribble into the chat any intervention that you think might make a difference. See, you're all part of the Curing Coma campaign. So nutrition. When do we start nutrition? 6 hours after their car crash? 6 days? 6 weeks? How much? What type? Do we use high nitrogen? You know, some countries, they start off with tea. They give the patient tea before they give the patient water. We do different formulas than you use. Some places, they just put stuff in a blender and squirt it into that tube. We don't know which is the best way. What about mobility? How frequently should you mobilize a coma patient? Like, should you have the patient come in and do bicycle legs with them? You know how you do with a baby, right? You take their fat little legs and move them back and forth, and you take their arms so big, right? I mean, should we play so big with our coma patient? Should we be flexing their hands? What about those bicycles now that they have, the mobile bicycles? What about the patient's sleep-wake cycle? Are you turning the lights off at night? Should you? Should we turn the lights off for 4 hours, 2 hours, 8 hours? Should it be really, really dark? Should we have the music on? How many of you play music? How many of you sing to your patient? I don't sing to my patient because I can't sing for squat. But I know Filipinos, y'all all sing. What about temperature? Should you have it air conditioned or warm? Should you touch them or not touch them? Should it be light touch? Should you poke them in the forehead all the time? What's the family's role? What do you let your family do for the comatose patient? Do you provide spiritual care? Do you provide for the family, for the patient? Do you let the family talk to the patient? Do you let the family wash the patient? What about the whole environment of care? When do you move the patient from the ICU to the step down to the floor to the rehab to home to skilled nursing? Are all those environments the same? If we do night in the ICU starts at 10 p.m. and on the step down floor, night starts at 8 p.m. Is that the same? Does it matter? I don't know. How often should we check their vital signs? How often should we get an X-ray or a CT? What about an EEG? Should we be looking at that every day? When should they get a tracheostomy? I want you to add to this list because we need all 1,000 interventions. One of the things I absolutely love to do for my patients is my family members wash the patient's hair. Nothing feels better than a good hair wash, right? And the patients seem to respond. I don't know, they kind of do, but they seem to. And all of what I'm talking about, all of these interventions, they live in this space here that if you look at translational science, the NCATS, the translational science spectrum, these are clinical research, these are implementation science, this is nursing, this is us, right? We're not, I mean, there are some nurses who do bench science where they look at cells in a microscope, but nursing, you know, we're really patient. Preclinical, that's like animal models, you know, that's the people who kill mice and rats and bop them on the head and stuff like that. Public health, nurses are definitely involved in public health, and it's really important, but public health, it's important for coma, but it's not the focus of the Curing Coma campaign. It's part of our campaign, but it's not as big a focus. So at the halfway mark here, and I recognize I've got less than an hour left, so I'm going to try to move a little faster. At the halfway mark here, I think I've hit my arguments. I have discussed the Q response theory. I've hit you with some statistics and made a couple of you have blood coming from your eyeballs. But I've really talked a lot about stroke. I mean, the Q response was some, but what about traumatic brain injury? I mean, when you talk coma, I said baseball bat earlier, and I think a lot of you resonate with that. Baseball bats, bullets, man, coma and traumatic brain injury, they go hand in hand. And I must let you know right off the bat, this is a great free access. If you have internet, you can access this set of literature. And this was by Pat Zrelak and Janine Yaha. And this is the evidence-based review of nursing care of adults with severe TBI. And this is available through the American Association of Neuroscience Nurses. And I'm sure that JC, sir, you can probably provide them with this link or these slides. I want to take you back to nursing school. I've taken you back to statistics class. Remember the nursing process, right? Well, the original nursing process was assess, plan, implement, evaluate. That's what I learned back in 1983. Assess, plan, implement, evaluate. And the new nursing process, you know, it's changed. Now they say it's assess, diagnose, nursing diagnoses. Assess, diagnose, plan, implement, evaluate. So we had the identify the patient's problem. Whew, we made a lot of progress in 50 years, haven't we? But I think it's simpler than that. And I think it's going to be a little bit different. So what is it we really do? Well, I think nurses, we're the eyes and the ears of the medical team. We assess and we monitor. We are front and center at the bedside. Literature says we as nurses perform over 3,000 tasks per day per patient. And I thought, what? What? Well, you got to understand, a lot of these tasks are cognitive tasks that we perform. I decide, here you go, right patient, right med, right route, right? Once I get the 5 rights for 30 meds, I've already made 150 decisions. How many decisions are you making for your patients? Many of these tasks are done simultaneously. At the same time that I am turning the patient, I am assessing the patient's skin while I take note of, does their heart rate change and what is their rhythm? By the way, has their blood pressure gone up from what it was an hour ago? We do lots of things simultaneously. Worldwide, 37% of the nurses have less than 2 years of ICU experience. The pandemic has hit us really hard. I have attending privileges at 2 different hospitals. And one of those hospitals, 80% of the ICU nurses were not there when the pandemic started. Only 20%, only 1 out of 4 nurses was there 2 years ago. There are hospitals that I know of that have 0 ICU nurses in their ICU who were in the ICU before the pandemic. Experienced nurses are valuable. I hope so, because I'm one of them. Think about these numbers as I go through the next example. This is going to be 2 minutes in the life of an ICU nurse. And I want you to think about this number, 3,000 tasks. So here's 2 minutes of ICU care. I need to take a big deep breath. You walk into the room to assess the vitals while you're giving while you're preparing the medications, and while you're talking to the family to teach the family about life after traumatic brain injury. Your intubated patient starts to cough and is coughing as you come into the room, and you look and you see that their ICP is open, so you open their external ventricular drain to get a little bit of cerebral spinal fluid out at the same time as you go up on the sedation medication, and then you're calling the pharmacy because you need a dose of hypertonic saline that was ordered PRN. Then you close the drain so you can see what the ICP is now while you're giving the hypertonic saline. At the same time, you're completing a neuro exam because this patient's ICP was going up, and you're watching the ICP waveform, not just the number, because you know that if the P2 is higher than the P1, that could be really bad. And you got to kind of document at the same time that you're doing this, while you're looking calm in front of the family, because you don't want to freak them out. And their biggest question is, what time does the cafeteria close? And you're answering that question as though it's an appropriate question. When the resident walks by and says, what's going on? You say, I need your help. And he says, oh, well, this isn't my patient. I'll go find a surgeon or something. I'll be back later. And but before he goes, he has another question about your other patient in the hall in room 3. And he wondered if you could get an EKG on that patient as soon as you got some time. And by the way, what is that patient's name again? I know he's down the hall in room 3. And so you got to remind this physician what this patient's name is. Well, your patient's herniated and he doesn't care. But luckily, the ICP has started to come down. You still need to move the patient up in bed because somehow they sluggered down. The resident doesn't have time for you to help you move the patient up in bed because he wants that EKG stat, because that patient had 1 PVC this month. And so you're trying to find someone to help you move the patient up in bed. You're also trying to figure out whether you should suction the patient or not suction the patient, because he had just had a cough and you know that his suction, his ICP might go up. So you're going to wait until the ICP comes down to below 12 millimeters of mercury. And when you realize that the pulse oximeter fell off his finger again, and you're trying to get it to work right, and then you had started to chart when that physician wanted to know what room 3's patient's name was, and that EKG that still needs to be done stat because of that one extra beat the patient had this day. And then the blood pressure started to go up. So you increase your nimodipine, your nicardipine to get the blood pressure to go back down. And then you cut back on the sedation a little bit. Maybe you'd gone up too high. You also notice that it actually, your blood pressure arterial waveform is kind of wonky. So you got to reposition the blood pressure. And you turn around, that physician is gone. And now you still got to move this patient up, and it's only been 2 minutes. How many interventions are in there? How many nursing decisions? Does it matter if you get them all right? What about if you make all the wrong decisions? I don't think the nursing process is accurate. I think the nursing process is not like you very cleanly go in, like, like nursing school when we all had our whites, right? You assess the patient. Oh, his ICP is going up. I've diagnosed that he has increased intracranial pressure, and I plan on bringing that down. And so I'm going to give him some hypertonic saline. I'm going to wait 3 minutes and evaluate if that helped. That doesn't work in real life. If you look at this event that happened, that model's more like this. You're doing all 5 of these things all the time. What's the importance of nursing? The importance of nursing is someone has to do this. Somebody has to do all this work. Someone has to be in the right place at the right time and make the right decisions in the right order. And without nursing, making all the right decisions, that patient is going to stay in a coma. I've already established for you that we do a lot of things. I've established that nursing is important. But how is it important? I still got to figure out this whole measurement thing. And I'll honestly tell you, I haven't figured it out. But I do know that my vehicle for figuring it out is going to be intracranial pressure, because intracranial pressure is ubiquitous to traumatic brain injury, right? When we think about ICP monitoring, we think about traumatic brain injury. They go hand in hand. It's like you can't find ICP without TBI. You can't find a Filipino that's not smiling. This is a picture of my friend Harvey. I met him about a dozen years ago, and I have never, ever seen a picture of him not smiling. We were out about 1 a.m. one night in the rain looking for something, pouring down rain in Cebu, and this man's smiling the whole time. Smiling and Filipinos go hand in hand like ICP and TBI. And if you want to know about ICP, you want to know about intracranial pressure, we all turn to the Monroe-Keeley doctrine, also called the Monroe-Keeley hypothesis. We think this is important. In fact, if you type Monroe-Keeley hypothesis into Google, 23,000 hits. Whew! 23,000 hits. There is an article from 2001 that's been cited over 930 times. Man, Monroe-Keeley is important. But who are these guys? Who's Monroe and who's Keeley? Well, it turns out that Alexander Monroe was a famous physician, and in 1783, he wrote an article called Observations on the Structure and Functions of the Nervous System, and he drew some pictures. On the right is the actual original thing, The one to the left is a reprint. It was 22 pages long. I actually have a copy and I've read it. It's kind of fun to read. And if you read it, part of that says, for being enclosed in a case of bone, the blood must continually flow out so that there's room for other blood to come in. This is the part that people attribute to intracranial pressure monitoring. He talks about blood. He talks a little bit about bone and brain in this 22 pages, but he never, ever, ever talks about cerebral spinal fluid. And I want you to keep that in mind. Then along comes George Keeley in 1824. Look at these dates, 1783, 1824. George Keeley wrote another paper. I'm going to read you the title. I got to take a big deep breath. This is the title of his paper. On account of the appearances observed in the dissection of 2 of the 3 individuals presumed to have perished in the storm of the 3rd, and whose bodies were discovered in the vicinity of Leith on the morning of the 4th, November 1821, with some reflections on the pathology of the brain. Part 1. That was his, man, was that a crazy title. You don't see titles like that now, right? This is, he dissected 2 heads from 3 patients. Well, patients. There were 3 soldiers on a ship, and that ship wrecked, and they got washed ashore in Leith. One of them was so badly decomposed he couldn't do anything with it. 2 of them, he cut their heads off, took them back to his lab. We would call this a case study. So we have 1783, and now we have 1824. 1783 was this guy who thought about some stuff, and 1824 is a case study. And in this case study, he says, if it's true, and it doesn't seem very conceivable how any fluid can come out of the brain without being replaced simultaneously by some other fluid. And the fluid he meant was blood. You'll see in a second why I know it's blood. And he never, ever, ever mentioned cerebral spinal fluid. So what he found is kind of the opposite. He said, you can't take something out without something else coming in. In other words, he discovered that nature abhors a vacuum. You turn a bottle upside down with a little cap over it, no fluid's going to come out. Unless something else comes in, that stuff can't come out. Unless that stuff comes out, nothing else can come in. That's all he discovered. Now, I know he didn't talk about cerebral spinal fluid because there's an interesting history to cerebral spinal fluid. In 400 BC, Hippocrates described that there was some fluid in the brain. He said it's like water. Then in 2000 AD, 600 years later, Galen talks about an excremental fluid in the ventricles that can come out through the nose. That's pretty cool. But then for the next 1,600 years, no one talks about this fluid. That's because when they studied the brain, they would cut the head off, right? You don't want to take that whole body into your lab. I mean, that's all. You only want the head. You only want the brain. And when they cut the head off, the CSF would drain out. They didn't know that. They just cut it off. So it wasn't until 1824, it was after Keeley published, that Dr. Magindi discovered cerebral spinal fluid. He said it was secreted by the pia mater. It's not, right? And he said that it drains through a foramen in the head. In other words, it drains out the skull. It doesn't. He got all that wrong. And he published in 1825. Now, the problem is we've recently discovered that this guy named Swedenborg, his son claims that Swedenborg discovered cerebral spinal fluid in 1744, but he never published his paper. His paper was published in 1887, long after he died. So either of those are well beyond Monroe and Keeley. Continuing the story, in 1828, John Abercrombie publishes something called Pathological and Practical Researches on Disease of the Brain and Spinal Cord. In this work, he's the first person to mention Monroe's paper and also mention Keeley's paper. Later, Abercrombie, who gave credit to his doctrine, Abercrombie's doctrine, later he said it was based on the work of Monroe and in part on the work of Monroe and Keeley. And it wasn't until 1846, remember 1783 was Monroe, 1846, George Burroughs tests the Monroe-Keeley hypothesis, adds cerebral spinal fluid to the equation, and publishes that the intracranial volume is blood plus brain plus CSF. That's when the first time that we start to see this called Monroe-Keeley. Monroe was already dead. This is that timeline. 1783 Monroe, 1846 George Burroughs, span of 63 years. The rest of the timeline is kind of interesting, and I'll go through it a little bit faster. 1890 is the first DVD. 1891, we use a pipette for lumbar puncture. 1903, Cushing's triad, you may remember. He describes that there's three things that are consistent with increased brain pressure. He never measured brain pressure, but this is what he hypothesized. Robinson was the first person in 1948, less than 100 years ago, the first person to measure intracranial pressure with a manometer. In 1865, Lundberg was the first person to use a strain gauge monitor connected to a ventriculostomy. 1865. Wow, not even 60 years. And then in 1987 was the first fiber optic device. And I was already practicing as a nurse before that. So the cornerstone of ICP monitoring is not the Monroe-Keeley doctrine. It's the Hippocrates, Galen, Monroe, Abercrombie, Keeley, Magendie, Swedenborg, Burroughs, Keene, Cushing, Robinson, Lundberg doctrine, and it's unproven. No one has ever proven that no one's provided strong proof that this is true. We say it's a closed box, but there's 50 different holes in this box. And it's based on two dead sailors who washed ashore during a storm in 1821. This is flimsy evidence for intracranial pressure monitoring, my friends. This you probably haven't heard much about, and I'm going to share some nursing research you haven't heard much about. And the reason you haven't heard much about it is because when physicians publish a paper, it's important. And when nurses publish a paper, we're like, oh, that's cute. We need to share our own work. If you want to monitor the brain correctly, you need a nurse who's going to do that. Here's some examples. Amato published that cerebral spinal fluid drainage does not work like we thought it worked. Rogers, along with myself, published that what we thought we wrote down, what you think you charted as the patient's intracranial pressure is unreliable. I followed that up with the project we did with Abdul and Hunt Bajer. All across the world, we did a worldwide survey, and All across the world, everyone does intracranial pressure monitoring different. We have different places that we reference. We use different units of measure, millimeters of mercury, centimeters of water. We treat it differently. We look at it differently. There's just nothing the same. These variances were confirmed with Molly McNett, who found that how we as nurses take care of patients is different all over the world. I did some work with Dr. Madavi and found that if you monitor pressure on the left versus the right, it's different. If we use an ICP bolt or an EVD, it's different. Molly McNett again published with Sarah Livesey and some others, Mary Kay Bader, that cerebral perfusion pressure, CPP, how you measure it, whether it's an art line or a blood pressure cuff, huge differences, huge differences. Michael Rogers published that you cannot get one ICP in an hour and have that be representative of all of the ICPs across that hour. Don Stout and Michaela Cortez published that when you go to radiology, there's all kinds of bad things. When you travel with the patient, how many of you travel and have problems? I looked at ICP ventriculostomy versus intraparenchymal. I compared an EVD and a bolt. We don't even use the same words. Sometimes physicians publish without even mentioning whether it was millimeter of mercury or centimeters of water. How we talk about it. Molly McNett again published another impactful paper, patient positioning. Who is responsible for patient positioning? That's us. That's the nurse, right? So nursing care does make a difference. How you read the ICP, fundamentally different. This is the paper that I was very pleased that this paper won Best Paper of the Year for 2021 through Connect. I was really pleased to see that. There's not a standard way to determine ICP. I published with some folks out of Harvard, we don't know how to wean a patient from an EVD. Once you put it in, how do you take it out? Here's the question I asked with one of these. Where on the upper left, where are you going to put the transducer? Are you going to level it to the ear? If you level it to the left ear, you can't level it to the right ear. What about the tragus? The tragus moves. Some of us do the outer canthus of the eye. Some of us do the tip of the ear. Lots of different ways. If you read the ICP tracing that's in the upper right, you could call it a 13, a 16, a 19, or a 22. Lots of people call them different numbers. This is this 100 is 1 second. This is 4.5 seconds of ICP monitoring. In 4.5 seconds, you can get 4 different numbers. Even if you call it the mean, one is a 16, one is a 19, there is a difference of 3. Huge differences. The importance of nursing for managing the patient in TBI is that we are responsible for the entire environment of care. Everything that happens in that room is nursing care. Physicians are not going to study nursing care. We must study nursing care. Not because they can't, but because they won't. This is an overview of the Curing Coma campaign. This is how it's structured. So you can see we've got 8 working groups. We have 9 modules. We have something called an aide de camp, which is a special assistant for the mission control team. Mission control team is myself, Claude Hemphill are the co-chairs. And then we also have Carrie Kim, Shraddha Manali, Lynn Polizato, and Jose Suarez. Our steering committee is a group of scientists as well as the scientific advisory committee. All in all, we have about 250 people involved in the campaign that are listed in some place you see. When they put a man on the moon, I want you to think to yourself, how many people were involved in putting a man on the moon? This was the NASA mission, right? How many people? And the correct answer is 400,000. I think curing coma is harder than putting a man on the moon, which means we will need more than 400,000. There is room for all of you on this screen. World Coma Day is going to need lots of people to help. Member sites, it's just organization. Now, if you want to be heavy into science and get involved in research, you're looking over at the working group, the science modules, common data elements, care of the patient in coma, that's mine, right? But the other portions, the infrastructure, is publications, implementation science with Dr. McNett and Lori out of California. Coma data science is really building a big database. Community of collaborators, engagement is spreading the word. Expert liaisons. Investigator toolkit is what all of you do every day. There are places for you to be involved. There's also places where there's nursing leadership looking for more nurses. I'm going to circle the places where there's a nurse who's a leader in the campaign. You ready for them? We have leadership and mission control, steering committee, in the SAC, in the working groups, in the modules. We have leaderships in the investigator toolkit, implementation science, publication, member sites, and World Coma Day. We have leadership in prospective studies and leadership in patient care. I know that these leaders are looking for nurses to be involved in the campaign. I know that I'm looking for help. Also, I should have circled aid to camp. These are special tasks that are can be done on kind of on your own time that are super helpful. That's the Curing Coma campaign. That's what we're about. This is why you as a nurse are fundamentally important to the campaign. We can't do this without 400,000 nurses. So I'm going to stop here, JC, and I'm going to switch over so I can turn on my camera and maybe take some questions.
Thank you, Professor Olson, for that very comprehensive presentation. Personally, as a nurse, I feel privileged to be here having the opportunity to listen to your topic. Now the floor is open to answer some questions.
JC, I want to
Yes?
prove I'm from Texas.
I think by simply your accent, you've already proven that to us. The floor is now open to answer some questions from our participants.
My accent. I ain't got an accent. All y'all got an accent.
Yeah, Dr. Daiwai, thank you so much for informing us a lot. And you have done a lot of courses today from statistics to nursing fundamentals about our nursing process. Now, really, it is really very important that we nurses at the bedside should pay particular and meticulous attention to the patients that we have, not only in terms of the vital signs, but also about the whole perspective of the person as a human being. And of course, the well-rounded, holistic, physiological, psychosocial, and everything. Unfortunately for us Filipinos, we also have problems. Our nurses are resilient. However, the system that we have in our acute care and even in our critical care does not permit nurses, particularly those working in not well-funded institutions, to really afford some time in trying to do as much as how many tasks in 2 minutes. That's about 300 or something tasks in 2 minutes. Because
3,000.
yeah, they do more, but unfortunately, it's not just for a single patient, but they do more because most of our nurses are assigned to so many patients. That's why they will not be able to see the subtle signs of each and every patient. They have to really be task oriented and not really do a meticulous assessment. So, what do you advise our nurses? Because I know the system is something that we have to adapt to, and our nurses may not be able to change the system. But as nurses, individual nurses, what can you advise pertaining to being more in contact, having their presence felt by a common patient?
Yeah, so that's a really good question, or a really good sets of questions. I want to give a couple. I see some people like Mark and folks out there that I've met, and so many people. Make sure I get to say hi. Um, Step one is what you're doing now. In the U.S., we were not always able to do the things we do now. In the US, we were not always able to have time at the bedside to work on other projects or to even finish our work. When I came to Dallas, the staffing was 3-1 in our ICU. It's now 1.5-1 because we turned to the literature and we advocated. I do not think you're going to change the entire country of the Philippines by noon. It's going to take longer. But you're doing that now. Some of the nurses who are on here who either have gray hair or should have gray hair if it wasn't for the advantage of coloring, know where you came from. We need to advocate for ourselves. That's huge. Joining organizations like CCNAPI, joining the PNA, becoming involved, increasing your education and advocating. That's part of our job. One of the things, and I'm going to be a little bit harsh to some of you right now, one of the things that makes the Filipino nurses so amazing all over the planet is our physicians love Filipino nurses, because the Filipino nurses, man, they just work like crazy. They'll work and work and work and work and never complain even once. They love that. But you also have to learn that you're not complaining for you. You're not saying this is too much work for me. You're saying my patient deserves more. My patient deserves more. My patient deserves that I am allowed to become a scientist. I am allowed to contribute to the world. I am allowed enough time to explain to this patient exactly what's going on. And that will make that patient's life healthier. And quite frankly, it's going to cost the government less money, right? If everyone in the world was healthy, there'd be no cost of healthcare at all. So we need to think about why we as nurses need to be advocates, and then we need to step up to the plate. So I'd love to see some questions. This is your chance to step up to the plate. Like right now, you can break through that little barrier of yours and ask a question. And I also saw Belan, who I've seen his name come by. Hello, thank you for listening.
Dr. Olson, we have a question here from Mr. Mark
Yay.
Santos. How can we participate with your ongoing research or future
Oh,
research?
thank you. Who asked that?
Mark Santos.
Oh, good. Okay, so my email was on the last slide. And maybe, JC, if you could type it in, it's dy.olson@utsouthwestern.edu. I can try to type it in while I'm talking, but I'll probably screw it up. So one is you can email me. Now, I get 200 to 300 emails a day. If I don't answer you right back, give me a chance. And I know that a lot of you love to connect on Facebook Messenger and things like that. And I'll try to check those, but I don't check them quite as often. If you email me, I'll get back to you. If you want to become involved in research, step one is to email me. Step two is to be honest. I need to know how much time do you want to spend, right? If you're like, oh, I want to spend 30 hours a week. Oh, well, that's a lot. There's a lot of research you can do there. But if you can only do an hour a week, that's okay. I got a place for you. I thank you for putting that in, JC. I have plenty of things that you can do to slowly get involved, to slowly become part of the international collaborations that we have. The screen that I showed you with, it's actually OLSON, not M. Do you see the typo? Otherwise, they're going to be emailing some other DIY. I don't know who that would be. Okay, so we need 400,000 people. Not all 400,000 are going to be spending 40 hours a week. One of the things with World Coma Day, if you type into YouTube World Coma Day shout outs, one thing you can do is we will have shout outs again next year. We got this many from the Philippines. 0, big old 0. This is a 2-minute video. You all got a phone. You got a camera. You can make a shout out video. Stories of hope. If you know a patient who was in a coma, right? Another way for research is I asked you to share with me variables. Myself, Molly McNett, Terry Green down in Australia, Peter in Germany, we're trying to figure out what are all the things that we do. There's thousands and thousands and thousands, and you can join us with that. And I'm not asking you to spend 40 hours a week. Do an hour, do 5. Let me know. Did that answer your question, Mark? He'll give us a yes or a no.
Okay, so Mr. Olson, for the last question, from an anonymous attendee, there are some studies say that turning schedule is not applicable, but still being practiced in the bedside for many years. What is
She
your
said
input
that,
on this?
so this was a question about turning schedule, right?
Yes.
This person is correct. There are studies that say turning schedule is not applicable. The reason we have the turning schedules, I can remember when this is back in 1980 something, I had 24 patients as one nurse, which was just kind of crazy. And there was just barely enough time to go around and turn them all. And in order to keep track of it, we turned them every 2 hours. And on the first hour, everybody faced the left, right? Then we'd sit and we'd chart. And then we go and everybody would turn to the right, right? So we go left, right, left, right, left, right. And then we put them on their back in the morning. So when the physicians came in, there's no science to that. That's just shit we made up. There is zero science that you should turn every 2 hours. How often, I'm going to ask you, JC, I'm going to pick on you. How often do you change position at night when you sleep?
At night,
Yes,
probably twice, I think.
every 8 minutes.
Mm, okay.
Isn't that crazy? We should be turning our patients every 8 minutes. On average, every 8 minutes. Right? How often have you settled down? Right? I want all of you, everybody listening to me right now, I want you to put your hands on your desk, boom, or on whatever, just put them flat. Don't move. Don't move a muscle. You're not allowed to move at all. Oh, you just moved, JC. You just smile. That's moving. Now look, you moved again, right? And now I want you to think about your butt. And you're like, ooh, there's some pressure. I want to do a little wiggle. Like I got pressure, right? Even when you think you don't move, right? We turn our patients and we're like, stay like this for 2 hours. And they're like, I got an itch. And we wonder why their heart rate's going up. There's no science to it at all, but there should be. This is one of my favorite things I would love. I don't know who asked that question, but thank you. Study it. Now you
So
can move. Now you can move.
thank you. It's very uncomfortable not to move. So
Isn't it hard? It's really, JC, really, it's hard to sit still.
I
Like really,
agree.
and here's another experiment I want everybody to do, and you'll get a different feel for your patients. I want you to lay down in bed, and however you land in bed, I don't care anything about you don't get to fluff the pillow or anything. You just lay down in bed, and however you land, see how long you can stay there. It's a fun experiment. It'll change how you treat patients. Sorry to interrupt you. Keep going.
It's okay. And for that, thank you again for accepting our invitation, Ms. Dr. Olson, and presenting a very informative topic. With that, let me award the certificate of appreciation to our speaker. So let me read the certificate. The Critical Care Nurses Association of the Philippines Incorporated award the Certificate of Appreciation to Daiwai Olson, PhD RN, CCRN, and FNCS for being our speaker during the online course on update on coma management roles of critical care nurses conducted April 6, 2022, signed by yours truly, the Vice President of CCNAPI, JC Agustin, and the President of CCNAPI, Maria Isabrita C. Rogado. Again, Dr. Olson, thank you. It's a great opportunity to listen to you.
Thank you, everyone, for taking the time.
Can we have the next slide? So as you can see in your screen that this online course is accredited by the PRC Board of Nursing and granted with one CPD credit unit. It's already after your post test and your evaluation, you will receive your certificate. So if you're going to look at your certificate, the highlighted numbers, that's your program accreditation number and the CPD unit granted. But before we show the link for your post-test and evaluation, let me invite you to our future activities. On April 16 to 19 to 21, the ECLS HCSI and the CCNAPI will conduct a basic EKG real-time interpretation training program. This is a 12-hour learning session that aims to enhance the nurse's comprehension in understanding the graphical depiction of the cardiac conduction system. Moreover, this program will provide nurses with a step-by-step approach that will help them develop skills in analyzing and interpreting cardiac arrhythmias. On May 10 to May 17, the Critical Care Nurses Association of the Philippines Incorporated will conduct a 22-hour course intended to provide the nurses with an overview of critical care nursing practice. This course will present the physiological concepts that will be the basis of understanding the most common illnesses that is related to cardiac, respiratory, and neurologic system in an adult population, and the common reasons for pediatric hospitalization. This course will offer an opportunity for nurses to develop critical thinking by integrating knowledge about the disease, assessment, nursing intervention, and collaborative management. And lastly, please mark your calendar. On June 16 to 18, the CCNAPI will be having their annual convention, and we will be hosting two international organizations, namely the World Federation of Critical Care Nurses and the Southeast Asian Federation of Critical Care Nurses. This event will be conducted virtually and live from 8 a.m. to 4 p.m. with more than 25 topics to be discussed and more than 3 interactive sessions. So if you're interested to be part in this momentous event, kindly just scan the QR code in your screen, or you can reach us through our email or messenger to know more about the said event. And for those nurses who will join this Congress, you will be entitled to a free 1-year CCN membership of CCNAPI with waive requirements. So kindly visit our website or our Facebook page for the announcement of the live Congress. So this is the QR for your post test and evaluation. We're going to post the link in your chat box. Please be reminded that this link will be open until tomorrow, 12 noon only. Before we end our program, again, I would like to acknowledge our invited speaker, Dr. Olson, for giving us your time and your efforts. To our participants, I hope you will be able to apply the knowledge you've gained in your area and even in your daily lives. And let's be part in curing Coma campaign. So if you have any for other information and concerns, please feel free to email us at ccnapicpd@gmail.com, or you can reach us at 0918-944-6897, or message us at our Facebook page, CCNAPI, sorry, tuloy na Bisaya, CCNAPI Nurses. So again, everyone, thank you and have a great day.